All right, this chapter is going to be on patient assessments. Patient assessment is one of those things that I tell everybody they need to become familiar with. They need to be comfortable with their own patient assessment. Okay, then you need to work with each other. As far as completing the patient assessment, um, and understanding if you're with another partner on a regular, y'all both need to understand each other's tactics and methods. That way that you both become familiar with the other one's patient assessment. Okay, they may not be in the same order. Um, However, they're covering and getting all the same information. Okay, so here's all the things we're going to look at: seeing size up, impact, environmental, impact of the environment on patient care, addressing hazards, balance, need for additional specialized resources, standard precautions, and multiple patient situations. All right, your primary assessment is going to be your level of consciousness to include your ABCs. Something you'll learn on the trauma side is that we'll take care of X, which is extenuating bleeding, and then we'll take care of the ABCs after that. Okay, but this is medical for for right now. So level of consciousness, AFPU, GCS, identify life threats, assessment of vital functions, initial general impression, and then begin interventions needed to preserve life, integrate treatment procedures needed to preserve life. So get your chief complaint, mechanism of injury, nature of the illness on your medical side, associated signs and symptoms, chest pains with radiating down the right arm with shortness of breath, possibly some nausea and vomiting, or do we have a major trauma situation where we're having hypovolemic shock due to multiple fractures, possibly arterial bleeds, something like that going on. Investigate that chief complaint using your sample, and then pass medical history and partner negatives. So, and then, we'll follow up with our secondary full body scan, focus assessment of pain, and then assessment of the vital signs. So some techniques of physical examination include, let's check on your respiratory system first. Make sure we have presence of breath sounds bilaterally. Anterior and posterior, please don't forget that. You got 3 on the right, 2 on the left. Cardiovascular system, is your chest rising and falling with your breath sounds? Are we having some secondary issues, maybe JVD, maybe tracheal deviation? Cardiovascular system as far as making sure that heart is pumping with radial pulses, pedal pulses, or we having to come into carotid and femoral pulses. Neurological system, is it intact, push, pull, squeeze, eyeballs, can we follow, the finger, all that different stuff like that. Musculoskeletal, can we move anything at all? Do we have some open and closed fractures? So what are we looking at there? Bleeding, possible need for splinting, maybe a full body splint with a backboard. So, all right, then we get out our monitor devices. Please remember that these are computers. They may be correct, they may be incorrect. So pulse oximetry is one thing. You don't have a pulse on radial pulse. Probably don't have enough capillary exchange to have a pulse oximetry, an accurate one. So, don't forget we need to go back to possibly end-tidal CO2. All right, non-invasive blood pressure monitor. Please make sure in your acute patients that you get that manual blood pressure, so that you can compare it to the non-invasive blood pressure, blood glucose determination, if needed. And that's one of those things now. I pretty much say is needed all the time. So, all right, how do we assess and reassess? How do we perform a reassessment for all patients? Okay, all right, so we're going to divide this up to 5 main parts. You just get your scene size up. What's the scene look like? What are we looking at? Do we have a safe scene? Okay, tall grass going into a medical call that is not well groomed. Are we comfortable walking through that? Could there be some critters or snakes or some pets that you don't see? Possibly some fight chickens, you can't never tell, on that scene. Or do we have I've walked up on scenes before, thought I had parked out of a scene. I get out, walk 2 steps, and there was a shell case and I landed on the ground. And that's just what I did. We were walking up. I kind of looked down. I think that call would come out as a wreck. Then it involves some gunshots, wounds, and there's just all kinds of stuff going on in it. But I walked up to the first law enforcement officer I seen. I said, "Look, bud, I don't know if y'all need to know it, but there is a shell casing down the street there, right by the ambulance. If you need to mark it." So at least somebody knew that it was there. Um, Primary survey was your ABCs, XB, ABC on your trauma patients. History taken, whether that takes you taking that from the patient or are we taking that from the bystander standing around. Okay. We get our initial stuff done. Vital signs, glucose, possibly end-tidal CO2, possibly IVs, whatever we need to do. And then we get into our secondary assessment, and then we reassess what we've already done so far. Okay, so this is the 5 breakdown points of this. A lot of questions throw you into one of these, and then you kind of have to go from there to understand the question. So making sure you understand how this is broken down is important in your test. All right, a sign, okay, is something that you observe with your eyes. All right, something that you can feel. Okay, a symptom is subjective condition that the patient feels. It's not something that you feel. It's something that the patient feels. Abdominal pain, chest pain, right leg pain. Okay, you see a right finger fracture. Okay, that is a sign to you. You see shortening or elongating of the right lower extremity. Okay, and then the chief complaint is the patient's reasoning as to why they called. Okay, in your critical thinking, effective clinical decision making depends on your ability to gather, evaluate, and synthesize the patient's information. So you got to be able to talk to these people. And it's going to be very hard to sit there and get their cell phone number or their Snapchat ID, and trying to talk to them over a phone in an emergent situation. So we have to learn how to talk to people. We have to get that rapport with them. That means sitting down with them, on their couch or wherever they're sitting, or walking up to them on the floor and being able to get that field impression after we talk to them and we evaluate what's going on. So we need to be able to gather their information, evaluate their information, and then synthesize the information together. So we need to be able to observe what's there, consider the meaning of the gathered information, and then collect all that, evaluate it, and form a plan to help manage this patient. Okay, always base your treatment and transport decisions on your assessment of the patient. All right, if information gathering stage, as you drive up, as dispatch is giving you information over the MDT, over the radio, however you all exchange information. Continuing situational awareness, consider a variety of factors, such as road and traffic hazards, incident hazards, scene of violence. And then your scene size up must be combined understanding of situation based on the information the dispatcher provides with your observation of the scene itself. Okay, so this is something that's always continuously going on. Okay, so consider traffic safety. Do we need to block traffic with our ambulance until some other apparatus can get there? So that we can help the flow of traffic also, so that we can keep our scene safe and also our patients safe. Looking for other hazards. Grease on the roadway, oil on the roadway can cause it to be slick. Is it just that hot that day? And the pavement may be melting, with the humid hot temperatures that we see here during the summer months. Is the floor safe, inside of a residence? Do they have a hole covered up going down the hallway? These are all hazards that we have to look for. Okay. And then we need to protect our patients and our bystanders. All right, determine the mechanism of injury, nature of illness. How did the patient become injured? Sometimes it's easy, sometimes it's very hard. How far was the fall? And was it a standing fall? Was it a fall off a ladder? Was it a fall off a roof? Did we fall off a Ferris wheel? Okay. Was it possibly suicide in nature? Things like that. How did a person get sick? During the pandemic, we were evaluating scenes and how many people here have COVID, have been vaccinated from COVID. And there was all kinds of things going on during that time. Okay. Right here. All right, we got blunt trauma on the top. Okay. In this picture, we got blunt trauma, possibly a seatbelt injury or a lap belt injury of some sort. Um, Usually the skin is not broken. Penetrating trauma occurs at a specific point of contact between the skin and the object. I mean, this could have easily been pinched by something. Maybe it's a close range GSW. Probably not, but anything's possible. It might be an animal bite or a human bite. It's kind of hard to tell. This is a pretty clean slice. It's probably a stabbing of some sort with a pretty sleek blade. It don't have very many ridges on it. All right, nature of the illness. And we got a history of seizures. Are we witnessing seizure, heart attack? Are we diabetic conditions? So it's often best described by the patient, their chief complaint, and the medical history in which you gain from your scene size up. We got all mental status patient there that nobody else is around. Hopefully they got a medical alert tag on. If it says something to give us clues on what to check, or do we go through the whole assessment of straight screens, acuity check, temperature check, all that stuff, just to see if we can narrow it down to what the automental status is being caused by. A lot of this stuff also can be brought forth by talking with the patient, the family, and the bystanders. So, and sometimes family bystanders kind of tell you more of what's really going on. All right, make sure you take your PPE. During COVID, we were wearing all of our PPE. I make fun of this, but something that we learned is what was in those little pouches that we had stuffed up there that were latex free back in the day. Or if we ran into a airborne viral infection of some sort, we found out what was in that little package. So that includes your N95s, your surgical mask, all that stuff. All right, so next we need to determine the number of patients. Are we at an MCI? Please remember that an MCI is something that is going to outsource your system itself. It uses up all your units, and you don't have anything left over. So we're going to need ALS backup if you're a advanced EMT or a BLS unit. We're going to need fire departments to come in and help us when we might have a possible carbon monoxide exposure, and they need to come in with their SCBAs. Or do we need law enforcement? There's a wide range of reasons we might need actual law enforcement on scene with us at times. Maybe a simple refusal. This patient sitting at home by themselves and something odd is going on, and we want that third party witness there. Don't forget about the ICS system. Make sure you understand it is kind of flexible depending on the amount of patients that you have and the incident itself. So make sure you understand how to start up triage, to allocate personnel, equipment, and resources so that they can provide the most effective care to everyone. All right, during your primary sort failure, your goal is to identify and initiate treatment of immediate and imminent life threats. Okay. We're going to look at our level of consciousness. We're going to get our ABCDEs or the EABCDs for your trauma patients. So it's not an in-depth physical exam. We're going to take care of life threats. If you have a medical patient for some reason that's bleeding and it's arterial, we need to try to take care of that quickly. Or do we have that medical patient that's pale and cyanotic, blood pressure's taken? Do we need to take care of this patient right here on the scene? Get their IV started. Oxygen started. Do we need to intubate to correct the airway? Do we have a spontaneous pneumothorax that has occurred? for some odd reason. So we need to take care of those life threats first. Then we get our general impression of the patient's appearance and position. Does the patient appear to have some kind of life-threatening condition? Were they injured? So all kinds of questions here that need to be answered right quick. All right, this is where we want to start our treatment next. You know, we got to get our treatment plan. We got to figure out what we want to do next. Are they unresponsive? Are they responsive with altered level of consciousness? Are they responsive with an unaltered level of consciousness? Then we need a sustained unresponsiveness indicates critical respiratory, circulatory, or central nervous system problem. Okay, after that, we're going to package and provide transport to the appropriate facility. This is part where we need to try to guess where our GCS is. Most of the time, most all receiving facilities now, if you have a altered level of consciousness, they're going to want to know what your GCS score is. Okay. Do we have enough do we have inadequate perfusion and oxygenation? So do we need to correct it? How do we need to correct it? And what it could be from? Is it from some medications, drugs, alcohol poisoning, hypoglycemia, chemical imbalances? All these are possibilities. All right, we need to assess your level of consciousness next. So test for responsive verbal stimuli, tactical and paper stimuli, and then ensure the patient's cervical spine is manually stabilized if there's any indication to establish spinal motion restriction. Okay. Any tenderness to the upper neck, to the back is probably more than likely an indication for at least the cervical collar. In today's time, we only use those, most of the time. If you use a backboard, that's fine. But it's not quite as recommended as it was at one time. So just make sure you keep that in the back of your mind. If you need to use that backboard, that's fine also. All right, use the AFPU score here. And then here's some ways that you can check for level of consciousness. All right, to determine whether a patient who does not respond to verbal stimuli will respond to pressure with a chest rub, sternum rub. So be very mindful doing these painful stimuli tests to make sure that you don't look like you're really trying to assault and batter the patient. You may have to explain why you're doing what you're doing. All right, look for your airway. Is it open? Is it adequate? Do we need to intubate? Do we have a foreign body obstruction that we can go and get out? So, all right, jaw thrust maneuver in your trauma patients. Others, you could probably use your head tilt chin lift, but it's just enough to open up the airway so that you can identify any possible causes of obstruction. All right, do we have adequate breathing? Do we have snore respirations for some sort? Do we have fast respirations? Not enough to actually have the chest rise and fall like it needs to, so that we can get that adequate exchange of O2 and CO2. Are we cyanotic around the nail beds and the toes? So do you hear abnormal breath sounds when listening to the lungs? And is the patient actually moving any air in and out? Okay. If it's too fast or too slow, we need to make corrections. If the chest rise is not equal on both sides, we need to figure out why. So, take the time to auscultate breath sounds. Okay. Understand if you need to get that quick supplemental O2 on board, but we also need to figure out what methods that we need to use prior to, administering that supplemental O2. Okay, with an nasal clean with a pulse ox at 94%, be okay on our MI patients. It could be that they are breathing normally. It's very well that they could be okay with that. Okay. All right, observe how much effort is required for the patient to breathe. Shallow respirations can be identified by a little movement. Deep respirations cause a significant rise and fall with the chest. And so you need to be able to document which way. Always document what your patient looks like upon your arriving. Okay, this gives you the ability to treat these patients the way that you feel that they need to be treated. Please remember, if you don't document it, they're not going to believe why you did what you did. So just keep that in mind. Okay, you know, we got that patient with some respirations, and you want to put an EPA down, that you going down your algorithm, find out that they're hypoglycemic. Okay, or you give that patient supplemental O2 after you increase the blood glucose, just to you know that there has no respiration to begin with. You're just going to give them a little bit for maybe 5 minutes just to get their oxygen levels back to where they're supposed to be. All right, there's the famous tripod position. The sniffing position, we're just going to tip the heel back just enough so that we can open up the airway, maybe open up the tongue. All right, palpate radial artery in responsive patients, radial artery, palpate the carotid artery in unresponsive. If they're less than 1 year, you want to go for the carotid. Hopefully, in a normal adult, it's between 60 and 100. We want to determine, do we feel one at all? Okay. Are we having trouble finding it? We having trouble finding it? What's our next step? Do we need to start chest compressions? So is it normal? Is it too fast? Is it too slow? Is it regular or irregular? Is it thready? Or is it like strong and balanced? We know we got a lot of pressure there. All right, if you don't get one, go ahead and start your chest compressions. If they're not breathing, go ahead and start your CPR, respirations assist. Okay. All right, assess the skin. This tells you that about the circulation, perfusion, blood oxygen level, and body temperature. So it's assessed by evaluating the patient's skin color, temperature, moisture, and capillary refill. So if it's determined by the blood circulating through the vessels and the amount and type of the pigment of the skin present. So if it's red when adequately saturated with oxygen and skin is lightly pigmented, pupil is pink. If it's deeply pigmented skin, changes color may be apparent only in certain areas. So assess the palm of the hands and the soles of the feet in children and infants. All right, inadequate previous circulation will change the appearance of the skin. In cyanosis, skin appears blue and gray. Around the mouth here, it is blue and gray. We're really red here in the central area. Start looking like we're turning blue here. Okay. So liver disease or dysfunction may cause jaundice, and that's usually greenish yellowish color there. All right, normal skin is warm to the touch. Abnormal skin is hot, cold, or clammy. It's significant when fever, sunburn, or hypothermia is indicated. Skin will feel cool when patients is in early shock, has mild hypothermia, or has inadequate perfusion, and the skin will feel cold in patients with profound shock, hypothermia, frostbite. So feel the patient's torso underneath the collarbone with the back of your hand to determine whether the patient's temperature is elevated or decreased. If dry skin is normal for as far as moisture, so if it's wet or moist from sweat or excessive dryness and hot, suggests the problem. All right, that's your capillary refill. This should be a review from AEMT class, but hopefully we go down to the nail beds. We paint, and hopefully that goes right back to normal color in less than 2 seconds. That talks about your circulation. Are we getting good exchange of O2 and CO2 in our capillary beds? So identify immediate control of any major external bleeding, and it should be performed before addressing airway breathing in your trauma patients. Tourniquets are there for that if you need it. So, all right, perform a brief neurological evaluation of the patient. Determine the patient's normal mental status. This is something that's going to be very complicated with your Alzheimer's dementia patients, patients that may be altered due to some chemical changes out of the body. So they may be alert at 1 second, and then they are becoming altered for some other reason. So that's something that you're going to have to keep a baseline on. I ask the family what's different. Do they know what's different? So GCS is here. So usually we use a person, place, time of event to gather how alert they actually are. But don't be afraid to use some oddball questions to determine how alert they actually really are. All right, do your full body rapid scan. So expect every area accurate, thorough assessment. We're really looking for the DCAT BTLS there, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Identify your life threats, recognize signs and symptoms of anxiety, loss of meaningful communication, lost consciousness, unresponsive to external stimuli, and then tongue possibly causing an obstruction. Airway obstruction, respiratory arrest is only really big life threat that we usually correct pretty quickly. Cardiac arrest, we usually start chest compressions pretty good. We usually started both of those at the same time. Severe bleeding, shock, obstruction shock, anaphylaxis, that kind of shock. All right. Next, we'll do our determining how quickly we're actually going to leave the scene. Your high acuity patients, should be spending only 10 minutes on the scene with these patients. Okay. Anyone else, we should be rolling out. Any kind of regular patient, medical patient, you do have the 20 minutes you can spend on the scene if need be. But usually most of us, those patients, they really want to go, we can get them loaded to do a lot of this stuff on the road. So, your transportation mode is going to be kind of up to you, what you're familiar with, who you're comfortable with driving. So be, think of that. Please remember that golden hour starts, when 911 is called and initiated, when the incident or the nature of the illness actually starts. All right. Your history taking provides details about the patient's chief complaint and an account of the patient's signs and symptoms. This is where you're going to have to become familiar with talking to your patients, gathering information from them, possibly bystanders. We're going to go through a sample, figure that out. With your pain, we're going to use OPQRST with the onset, what provokes it, what quality is it, exactly where it's at. Does it radiate down? Or is it just like diffuse pain somewhere? Or is it focal pain in one little spot? Okay. Radiating pain travels to another area, refer pain exits in more than one place. The severity of it, using your pain scale possibly, or just talking to your patient, see how bad it actually really is from their actions. And then the timing of it, when did it start? Has it been intermittent pain? Has it been constant pain per X amount of time? Right. What happened before you got there? A lot of dispatchers are able to direct patients and direct people that call 911 on certain things that they can do prior to you arriving on scene. That includes aspirin, Narcan, possibly the initiation of chest compressions. So ask about that stuff so that you know how to proceed from there. Identifying your pertinent negatives, expected findings based on the patient's complaint, but that are not present. Use your sample. Okay, please don't forget about it. Any alcohol, drugs, physical abuse, violence, when you talk about those. Any of these, you probably need to involve law enforcement on both of these, not just the physical abuse and about violence. All right, sexual history for those that it all is recommended for. Okay. A silent patient, special challenges. We might have to use our closed-ended questions, or we might have to start with open-ended and then go to closed-ended. It's just going to kind of depend on your patient and what their challenge is. Right. Our targeted patients could be used for caffeine or amphetamines or nervous, or they could have been ingesting things. Okay. Multiple centers spend extra time assessing the patient and prioritize the complaints. We do this a lot of times. Patients call us complaining about several different things, and they don't really correlate to each other. We need to kind of figure out which one the patient is actually trying to get assessed for today. Which one prioritizes over the other. A lot of people think they complain of chest pain and go straight to the back, and they really have some kind of toe pain, and it changes when you get there. Um, some patients are really anxious about getting on the ambulance. They think that they'll never come back home. So psychological shocks. I want to know that once they leave the house, they may be going to other places that they don't want to. So just be aware of these responses and anticipate possibly hysterical patients and possible violent patients. So do not take anger and frustration personally, and do not become angry at yourself. So try to remain calm, reassuring, and gentle, and always be observant. Histories to intoxication can be difficult. Crime can be difficult. Depressed patients can be scary at times because you don't know what's going to set them off. Some of them have this hopelessness about them, and they don't want any help. They don't think there's any more help for them. But getting reassuring those patients, alcoholic patients, crying drunks, probably one of the worst drunks. And a happy drunk can sometimes be one of the most worrisome patients too. They're always picking at you or doing something crazy. Let these patients express themselves. Let them get some stuff off their chest. So confusion stories are possible. Cognitive abilities. Keeping questions simple depending on how cognitive the patient really is. So, all right, language barriers. Try to find interpreters, translators, mobile app devices if you can use them. Proper hand gestures. Please be careful with those if they're not exactly, if you're not really familiar with what hand gestures are really need to be used. Don't always holler at your patients, even though they're hearing impaired. Use your pencil and paper. I've typed on my notes app on my phone before to be able to communicate with patients. Identify yourself verbally and stay in contact with the patient. So get your vital signs, perform your systemic physical exam. Look for all these things here, be able to document them, each one of them. On that beginning pulse ox, I usually try to get that remember as much as possible, especially in those respiratory patients. Get your vital signs, pulse oximetry. It could be indicative of bronchodilator therapy, possible artificial ventilations if needed. Please remember that it is a machine, so it could be incorrect. If you take a radial pulse and don't get the same pulse rate that you're getting on that pulse oximetry, possibly got an inaccurate reading. Carbon monoxide exposure is also going to be wrong. So please remember to get auscultated blood pressure prior to getting a non-invasive one. Internal CO2. are good indicators of your respiratory status of your patient. Even with the nasal prongs, if you have those work excellent also. Okay. As we go through respiratory, we'll teach you a little bit more about your entitled CO2 and your endotracheal tubes and your king airways. Blood glucometer, please make sure that any kind of patient has an aorta level consciousness, you're getting this so that you have this documented correctly. All right, in your secondary assessment, you're going to do your full body exam, probably going a little bit more in depth, checking your abdomen in 4 quadrants or 9 quadrants, pelvis area, sensation. Your focus assessment here based off your chief complaint. Your respiratory system here, what you're looking for. So making sure the respiratory rate's normal, the rhythm's normal, and if it is abnormal, what are we going to do to fix it? Okay. Possible decreased breath sounds on one side. Excuse me. Stridor, upper airway has a mild obstruction caused by a foreign body, bubbling or gurgling. And then make sure that you check your lung sounds, anterior, posterior, and your midclavicular fields. And then being able to recognize each one of these. All right, cardiovascular system, we're going to look at these. It's tachycardia, bradycardia, if it's greater than 100 or less than 60. Distal pulses, check for abnormalities in the thoracic region. Pulse quality strong, bounding, weak, or thready. Is it regular or irregular? Decrease in blood pressure maybe indicates loss of blood or its fluid components, loss of vascular tone, or sufficient arterial constriction, a cardiac pumping problem, or overdose of a beta blocker or hypertensive meds. So, being able to differentiate between your systolic and diastolic, and then what methods you really want to use. Also recognizing hypotension and hypertension depending on the system that you work in. All right, with your neurological system, you want to be able to assess, evaluate the level of consciousness and orientation. Use the AF, put in the GCS. Pupils are the echoreactive reactors, one constricted, both of them constricted. Is one dilating faster than the other? All kinds of things that can go there. And here's your perla, pupils echoreactive reactive, the light, and the computation. And your head, neck, and spine is inspected for abnormalities, palpate the scalp, and check face for rash. Assess the eyes, check for bruising discoloration around the eyes, check the ears and nose for fluids. So the odor suggests the need to check for blood glucose level and check neck for swelling or bleeding and palpate for signs of trauma. All right, inspect the chest, equal rise of bone, paradoxical motion, if possibly with fractured ribs, and then make sure you auscultate the breath sounds. All right, we'll palpate the abdomen. If they are complaining of a specific region hurting, please don't start with that region. Go to the other ones, and then possibly come back around. We got bruising over the flank area, so blood collecting in the retroperitoneal space. Asymmetric may be suggest a swollen organ. Severe distension may be caused by fluid accumulation, and then test for rebound tenderness, possibly going up into the shoulder area, radiating downward. All right, check the AAOS, make sure it's symmetrical, stable, possibly any tenderness and bleeding or crepitus, deformity in that area. It's usually not done in medical patients. So, We want to look for external bleeding in these areas, possibly, and where it may be coming from. All right, decap PTLS on the extremities. Check for pulses, motor function, sensory function. Palpate each one individually. Expose them if needed. Then we want to check her back for the same thing. Okay. You need to be able to identify what happened, what you found, what may be the problem with each body system, and what treatments that we choose from there. So, and then once we start treatment, we're gonna go back over all this stuff, reassess our pulses. Do we splint on a particular area? So we need to go back and reassess pulses in the area, reevaluate strength, grip in that area. So then reassess your vital signs. Okay. All right, go back over your G complaint. Has it gotten better? Has it gotten worse? Has the pain increased or decreased? Are we easier to breathe? Are we getting more shorter breath? So, and possibly if there's any new problems that need to be dealt with. And then making sure your interventions are correct and they're maintaining. With each respiratory, that ET tubes will have to be checked many different times with breath sounds, making sure it stays in the correct spot. All right. Stable patients every 5 minutes and stable patients every 15 minutes.